coming in.
Good afternoon, everyone, and welcome to the Prenatal through age 25 Behavioral Health Legislative Implementation webinar with Q&A. As we get started today, just a few ground rules and housekeeping. We will have you on mute. So if you can make sure that you are on mute, we can also do that for you if you have trouble. Raise your hand if you have a question and have something. This time is for you. So we welcome any questions, comments, and feedback. We will like to hold questions till the end of the presentation. So please feel free to add them into the chat, and we will definitely circle back to them. If we can't get to yours and or can't answer in this meeting, we will follow up with you afterwards. A quick disclaimer, this meeting is being recorded and will be posted to the Prenatal webpage at HCA. And the recording is open to public disclosure. So we encourage you not to share any private or confidential information during this presentation. We do have a pretty robust agenda today. And before we dive in, I will turn it to Diana to say a few words and kick us off. Diana.
Thank you, Jennifer. Good morning, everybody. Good afternoon, everybody. Thank you for joining us today. My name is Diana Cockrell. I serve as the Section Manager, Prenatal through age 25 Behavioral Health, which means substance use and mental health services in Healthcare Authority. Some context and framing for this particular update series that we're doing. In the 2022 legislative session, House Bill 1800 gave us resources to support communications for this section. And through that, part of the work we get to do, supported by Jennifer, is share out implementation updates with the hope of creating a line sight into what's happening when things are in the works but not yet visible on the outside. This is our second year of being able to share our updates this way. So they're recorded and they are online if you're curious about past ones. In the section, the Prenatal to 25 Behavioral Health section, we have roughly 10 to 15 different efforts that we're in implementation on. And we also have roughly 20 to 25 programs and policy initiatives on the team that have moved from implementation over the years into being established programs. So this is an incredible team of people that I'm really grateful to get to work with, who you will get to hear from some of them today. So the part of our work that today's presentation will be on is the legislative implementation pieces. For each one of these presentations that are on the agenda here, you'll hear a bit about the language in the bill or the budget proviso that funded it, a rough timeline for the work, and where we are in the process of rolling it out. Please participate freely in chat as you'd like, and we'll either respond in chat if it's connected to legislative implementation, or gather it up and follow up with you if it's connected to other work you have questions about, or potentially save the questions for Q&A at the end of the presentation. Again, thank you for joining us today. And to the presenting team, thank you for your courage and willingness to step into the challenge of presenting your work today in this format. With that, I will turn it back to you, Jennifer.
Thanks, Diana. So let's just dive right in. Ashley Pina is going to talk to us a little bit about Grace Harbor. Ashley.
Thank you. Hello, everyone. My name is Ashley Pina. I use she and her pronouns, and I am the Pregnant and Parenting Family Substance Use Disorder Policy Administrator within the Division of Behavioral Health and Recovery, and I am lead on the Grace Harbor project. Next slide, please. So on this slide, we're going to find the Grace Harbor project proviso language. It instructs the development and operation of a 16-bed substance use disorder inpatient treatment facility in Grace Harbor County, specializing in treating pregnant and parenting individuals and their children. The facility must allow for parents and children to reside together while the parent completes treatment. The authority, which is me, must contract for these services through behavioral health entities in a manner that allows for leveraging of federal Medicaid funds to pay for a portion of the cost. The authority must consult with the Department of Children, Youth, and Families in the implementation of this funding. Next slide, please. So the operating budget section for this proviso is the total funding for the project is $1,703,000 for the fiscal year 2025. And of that, 568 is for documented startup costs. If a provider, however, can begin developing services before June 30th, 2024, I will notify the Office of Financial Management and the appropriate committees of the legislator, and submit a request for funding in the fiscal year 2024 for a supplemental operating budget. Otherwise, the implementation of this funds will begin in the fiscal year 2025. Next slide, please. So in partnership, and as instructed by the proviso, in partnership with DCYF and other cross-agency stakeholders, a family preservation model has been defined as a family preservation model is a multifaceted approach to substance use disorder treatment across the continuum of care. The model integrated into a residential treatment facility serves pregnant and parenting individuals and their children. The I in PPI includes fathers and couples. The model is equitable, serving underrepresented vulnerable populations, incorporating an interdisciplinary approach to reduce barriers for families. The model is culturally centered, designed to serve diverse family system. The model aims to provide trauma-informed care through a person-centered approach and/or a family-centered approach. A goal of the family preservation model is to keep families involved in child welfare systems safely together or to work towards reunification. The heart of the model is whole family-centered healing. Next slide, please. A substance use disorder residential treatment facility serving pregnant and parenting individuals and their children. Implementing a family preservation model must provide on or off-site services, including but not limited to the components outlined in this slide. I will leave this up for a few moments so folks can read through that. Next slide, please. The current status right now for the Grace Harbor project is there's a procurement process for the Grace Harbor project, and it is going to be a two-part competitive procurement process. The goal is to have a provider contracted and services begun on or before June 30th, 2024. Thanks so much.
Thanks, Ashley. We really look forward to what this program looks like in launching in 2025 and your continued work on getting that off the ground.
Awesome, thanks.
Next, we'll go to Sarah Pine, who's going to talk a little bit about Parent-Child Assistance Program.
Thank you. Good afternoon, everyone. My name is Sarah Pine, and today I will be sharing information on the Parent-Child Assistance Program and the upcoming rate increase. Next slide, please. The Parent-Child Assistance Program, commonly known as PCAP, is a 3-year intensive case management program. There are currently 15 locations statewide, serving a total of 20 counties and currently contracted to serve just under 1,500 clients. PCAP is funded by both Medicaid and state dollars. Next slide, please. Anywhere from family planning to legal services, PCAP assists clients in learning to access and use local resources that cater directly to each client's individual needs. This also includes linking clients to substance use disorder treatment, establishing recovery, and supporting parents with their child's individual needs as well. Next slide, please. In this budget overview, you will see the funding that supports the upcoming 15% rate increase that each PCAP site will receive effective January 1st, 2024. This language is already in contract and set to begin on time. Thank you all for your time today.
Thanks, Sarah. We will now move to Tina Burrell to talk to us about caregiver respite.
Thank you. Good afternoon. My name is Tina Burrell and I use she, her pronouns. And I'm honored to do an update on caregiver respite. I'm going to do a bit of historical context and then a point in time update. First slide or next slide. So Washington State did have respite services for a number of years under a Medicaid waiver, and that came to an end in 2012. Currently, respite is only available through state or local funding. However, in 2017, FISPERTS, our Youth and Family System Roundtable, Family, Youth and System and Partner Roundtables recommended a need for respite based on feedback from youth, families, and stakeholders that this service was missing in our continuum, and they were feeling the need for that. This recommendation came forward for behavioral health respite for youth to meet the needs for our most complex youth in Washington State. They took this recommendation forward to the Children's Behavioral Health Work Group, presented it there, and that work group also supported it and moved it forward as a legislative request and recommendation. In 2021, Healthcare Authority received a proviso based on this request, directing us to create a report that reviewed Medicaid authorities on how we could fund respite services in Washington State. That report was completed in June of 2022. And that was the end of the legislative mandate, was to complete that report. However, HCA wanted to continue forward. Our leadership at Healthcare Authority looked at the various options, and one of them identified was the 1115 Medicaid waiver, known in Healthcare Authority as the Medicaid Transformation Project. And it so happened that we were in the process of renewing this application, which only opens up every 5 years. So we added, they had been working on this application, but we added the request for respite services. I will note it did go for behavioral health respite for youth to caregiver respite. And that strategy was, because it was a little late putting it into the application, and also California had just had theirs approved for caregiver respite. So we moved that forward, which encompasses what we currently have allowable for respite. And the benefit from that is it is lifespan. And not just for youth. So I want to shout out to our FISPERTS for helping move this forward. Next slide. So this slide and the next one are really a visual graphic, and I'm not going to go through all of these items. That is under the MTP project, the Medicaid Transformation Project. All of this work is allowable under the waiver and moving forward. In the middle of this graph, you'll see some golden boxes there, and these are the health-related social needs services, and that is the category, the HRSN services, that caregiver respite falls under. There's also 9 other services in that category. You'll also see Native Hub and Community Hubs, and I'll talk about that a little later. Also want to highlight all of the MTP programs support Apple Health Medicaid enrollees. Next slide. So this is another slide to show sort of the menu of services that are in the health-related social needs services. There are 9 other ones, not going to go through those, but 9 other ones that are on the menu in addition to caregiver respite. Next slide. So for caregiver respite, CMS has provided a definition that's on the screen, and I'll read that for you. Intermittent temporary supervision provided on a short-term basis in the enrollee's home, a healthcare facility, or an adult day center. Services provided to the enrollee are primarily non-medical and may include attending to the enrollee's basic self-help needs and other activities of daily living, ordinarily performed by a caregiver. So this is giving respite relief to the enrollee's caregiver. To qualify for this, and this is broad, enrollees who live in the community and are compromised in their activities of daily living and/or have been assessed to have a behavioral health need and whose unpaid caregivers require relief to avoid an enrollee being placed in an institution, or my preference, a higher level of care. But again, this is what was approved by CMS. Under development are all the mechanisms to get this service out, which includes the delivery service options, the coverage criteria, so is who is going to receive the services, what are the services, allowable providers, credentialing, and cost effectiveness. So all of these items, though, has been approved by CMS, we need to have a sort of full package that meets medical appropriateness and evaluation again by CMS. Next slide. So to roll this out, there are two pathways. We will have a fee-for-service pathway and a managed care pathway. And the fee-for-service, the fee-for-service is going to go through the hubs that I mentioned earlier. There'll be one native hub and 9 community hubs, and they'll be contracted to hold the menu of services. In the managed care side, they will run through the managed care organizations and contracts in a lieu of service process. And in lieu of service allows Medicaid managed care plans to pay for alternative services instead of standard Medicaid benefits when it's medically appropriate and cost effective to do so. And so we're going to use a combination of the waiver authority for fee-for-service and in lieu of services for managed care. The long-term goal is to move perhaps in a state plan and continue to use in lieu of services for long-term sustainability. Right now, and this is the point in time update, the only established deadline or anticipated timeline for this work is to launch the hubs, the native hub and the 9 community hubs by July of 2024. They'll be the contract holders, and once those are established, they'll identify deadlines for phasing in and implementing the other services for the HRSN services. And the lead for this work is the Healthcare Authority MTP team. Thank you for your time.
Thanks, Tina. Moving on to Sherry to talk a little bit about the Youth Mobile Response and Stabilization Services and how it rolls into the 988 in Washington Crisis Plan. Sherry.
Thank you, Jennifer. Good afternoon, everyone. My name is Sherry Wiley. I'm the Youth Mobile Crisis Team Administrator here at HCA on the Crisis Systems team. My pronouns are she, her. And I'm going to go over some crisis system legislation and the youth best practice model. Next slide, please. In July 2020, the federal government designated 988 as the number to call for people in crisis, so they didn't have to remember a 10-digit number anymore. As you know, 988 went live in Washington last year, and calls to 988 are being answered in-state by 3 988 Lifeline Crisis Centers. These Lifeline Crisis Centers do great work. They are confidential in nature, and they have an impressive over-the-phone and resolution rate. All other crisis lines remain operational. In 2020, SAMHSA released a best practice crisis care toolkit for adults, and in 2022, SAMHSA released guidance for youth best practices, and NASHBID released its companion report, A Safe Place to Be, which means that we want to stabilize youth at home whenever possible. Next slide, please. In 2021, Washington passed House Bill 1477, establishing the Crisis Response Improvement Strategy Committee, a steering committee, and subcommittees, including a lived experience subcommittee, which has no limit for participation. It also calls for a technology platform and a crisis contact center hubs that will eventually dispatch crisis teams. This year, House Bill 1134 added a geolocation subcommittee and ensured a vote in the steering committee for the lived experience subcommittee. It also created a voluntary endorsement for mobile rapid response crisis teams, which includes youth teams, to receive an enhanced case rate. Teams will get additional performance payments if response times in the bill are met. Next slide, please. Last year, we sent out proviso funding to each of our 10 behavioral health administrative service organizations to ensure at least one adult and one youth team in each region to respond to calls to coming into 988 when it went live. A SAMHSA System of Care grant is supporting MRSS rollout statewide. And Washington has been participating in a national quality learning collaborative with peer state leaders in the youth best practice model, mobile response and stabilization services. For time, I'll be using the acronym MRSS for the rest of the presentation. Next slide, please. This time last year, we only had 4 youth mobile response crisis teams in the state. We've tripled the number of youth teams to 13 and tripled the counties with dedicated youth mobile response team coverage from 5 to 17. These teams are building capacity and have received developmentally appropriate training in harm reduction, de-escalation, and trauma-informed care. And we also put them through an HCA-sponsored Certified Crisis Intervention Specialist 2 training. The System of Care grant is funding an MRSS 101 training, and the team is partnering with the University of Washington for evidence-based practice trainings. Next slide, please. The adult crisis model consists of someone to call, someone to come, and somewhere to go. For youth, we don't want to transport them anywhere. So for youth, the somewhere to go is a safe place to be, sometimes known as a safe place for help. MRSS goes wherever the youth is. Next slide, please. The goals of MRSS are to reduce the use of emergency departments, inpatient stays, and juvenile justice involvement for behavioral health needs. Teams support and maintain the youth in their current living situation. Kids sleep in their own beds. They do this by promoting safe behavior in homes, schools, and communities. And they assist families to access natural and clinical supports. And they break down barriers to care through outreach and engagement with youth system of care partners. Next slide, please. There are 2 phases to MRSS. MRSS meets a sense of urgency with urgency when families call, teams go. They're going to respond with a clinician and a parent and youth peer and provide developmentally appropriate engagement, de-escalation, safety planning, and can help support caregivers in keeping kids safe at home. They can follow up for up to 3 days. Next slide, please. If the family has additional needs or has additional needs or that need additional support, there's a separate but connected in-home stabilization phase for up to 8 weeks. During this phase, they promote safety at homes, schools, and communities, provide psychoeducation, skill building, and work with the family to identify and connect them to community supports through wraparound principles. Teams will make referrals and provide warm handoffs to the right level of clinical care to ensure connection, thus preventing return to the crisis phase. Next slide, please. Healthcare Authority contracts with 10 behavioral health administrative service organizations for crisis services. The graph on the left shows in days what youth currently get when they access the crisis system. All kids get that crisis intervention phase in green for up to 72 hours, insurance blind. 2 regions are providing the stabilization phase for up to 8 weeks. That's King and Thurston Mason through rated unsustainable funding. This includes some local funding, which creates data issues here at HCA, because if we're not funding the program, the data isn't sent up to the state. The System of Care grant is supporting direct service stabilization in Pierce and Spokane. The graph on the right is the goal. This is the future state that all youth get the full MRSS package. We just got a state plan amendment approved so that teams can provide more than the current 14 days of in-home stabilization. And this goes into effect January 1st, 2024. We also added peers to crisis services. Next slide, please. This is how most families currently access crisis services. All of these people tell parents to take their kids to the emergency department when there's a behavioral health need. When a caregiver calls a crisis line and we don't send what looks like help, they're going to hang up and call 911. 911 is going to dispatch either EMS or law enforcement, and they will be happy to transport to the emergency department or worse, juvenile justice. Washington State has a well-known adolescent hospital boarding issue. House Bill 1580 passed this year creates a multidisciplinary team housed in the governor's office to address this. A 2022 study by Mary Bridge Emergency Department in Tacoma found that for youth who went to the emergency department for behavioral health needs that year, 61% of families reported negative functional impacts associated with long lengths of stay at the ED. 33% of youth reported that the emergency room visit wasn't necessary or that it made things worse. And the study concluded that the top possible diversions across all means of arrival to the emergency department were mobile crisis outreach teams at 98%. So we want to shift from a risk-averse medical model that requires evaluation and treatment in the emergency department for behavioral health needs to believing and understanding we can keep kids, even those with some level of risk, safe at home. Next slide, please. Through a recovery lens, MRSS is delivered to the family at homes, schools, and communities. In some regions, people call the provider line or the regional crisis line to access MRSS teams. Anyone can make referrals to youth teams, and they'll respond wherever the youth and family is. If a family is calling a public system for help, they need help. MRSS screens in, not out, and allows families to define the crisis and respond in person when young people, their caregivers, or third parties like schools or law enforcement identify a youth in need. We want the right intervention delivered at the right intensity and at the right time. Next slide, please. This slide shows the regional crisis lines where you can access youth MRSS teams on the left. 988 is in the middle. When you call 988, there are four dial pad options. You can press 1 for the Veterans Crisis Line, 2 for the Spanish line, 3 for the Trevor Lifeline, and all 3 of these are answered out of state. You can press 4 for the Native and Strong Lifeline, which is answered in state. You may remember that 988 Lifeline crisis centers are confidential in nature. And the 988 contact hub in orange that will eventually dispatch teams is future state. There is also a text and chat option for 988. Lifelines may have the goal to resolve as many calls as possible by phone because it seems like this would save time and money and be less invasive to the people we serve. But if families don't get what looks like help when they ask for it, they're going to call 911 or go to the emergency room, which is more costly and traumatic. Next slide, please. This is a quick reference slide on MRSS and what to expect. Remember to call your regional crisis lines to access these teams. Next slide, please. This slide has the regional crisis line numbers listed by region, and the stars represent the locations of youth teams. To recap, I just want to remind you to text or call 988 for confidential over-the-phone support and call your regional crisis lines to access your regional crisis system, including these youth MRSS teams. Thank you for the opportunity to present today.
Thank you, Sherry. This is a very complex program, and very grateful that you're at the helm of it. This is a lot for people to unpack, and so I really want to make sure at the end that we leave room for questions for Sherry, because this is really your time to have the expert in the room. So thank you, Sherry. Next, we will move to the prenatal substance exposure bill. Typically, this is presented by Christine Mickelson, but today it will be presented by Diana.
Thank you. Hello. I am Diana and covering for Christine Mickelson today. She will supervise the person doing this work once they're onboarded. Next slide. There are 4 main sections of this bill. Today we'll go briefly over what's in it, a big picture, and then we'll dive in. Next slide. One of the goals of this bill is to improve treatment services to individuals who were prenatally exposed to substances and their caregivers. Services such as occupational, speech, and language therapy, sensory process support, educational advocacy, and psychoeducation will be included along with behavioral health counseling for individuals and caregivers. Another important piece is linkage with community resources and education support. Eligibility for services related to this work will be children 3 and over who've been prenatally exposed to substances, and families who are or could potentially be involved in or at risk of involvement with the child welfare system. The intended outcomes of these services are to maximize the numbers of families that can be served, keeping families together, reducing the number of placements, and prevent adverse outcomes for children who've been prenatally exposed to substances. Next slide, please. There are 2 recommendation reports for this work that will be coming out. The first one will be in 2024 and the second in 2028. The reports will cover expansion of services for this population and recommendations to improve availability and access to services, including exploring Medicaid coverage and outcomes experienced by individuals receiving services and their recommendations related to improving outcomes. Next slide, please. To round out the work laid out in this bill, an interagency agreement with Department of Children, Youth, and Families and the Healthcare Authority to ensure identification, coordination, and intervention for both children with prenatal substance exposure and for individuals who identify as women who are at high risk of having children with prenatal substance exposure. This agreement will allow for community advocacy groups to participate in the development of the program. And we are currently in the process of hiring the position, working through the recruitment pathways to add a team member to lead this work. And with that, I will hand it back to you, Jennifer.
Thank you, Diana. Last but certainly not least, I will turn it to Edward to talk a little bit about the Kids Mental Health Washington program. Edward.
Good afternoon. Edward Michael. I am the Kids Mental Health Washington Administrator. This program was formerly the Youth Behavioral Health Navigator Program. Next slide. The goals of the Kids Mental Health Program consist of having regional teams that can support children, youth, and families within their own communities, develop an effective access point or portal for anyone concerned about a child or youth to reach out for support. These teams are composed of diverse regional-based experts capable of identifying community-based partners with resources and prioritizing the needs of children and youth needing intensive services. Next slide. In the 2021 legislative session, lawmakers funded the existing Kids Mental Health Pierce County program and funded them to provide technical assistance for the rollout of the Kids Mental Health Washington program across the state. In that year, there was funding for 3 additional regional coverage, which consisted of Salish, Greater Columbia, and Southwest. The Behavioral Health Administrative Service organizations were identified to roll out the implementation and were offered the opportunity to self-select the implementation order, selecting which year they would stand up their team. The second year, which started in July of this year, North Central, Spokane, and Great Rivers came on board. And then, as you see in the purple asterisk, Thurston Mason, they were slated to come on board in the 3rd year. However, due to ARPA funds that came available, Thurston Mason region stepped up and agreed to be part of the implementation for this year with those ARPA funds, and then they'll switch to state funds in the next year once state funding becomes available. Additional ARPA dollars are going to year 1 regions to explore and pilot multi-county implementation, and as well as to be used to support web design and the startup of the Kids Mental Health Washington for upcoming regions. Additional funding was used to support the amazing work of our TA team and continue to meet the multiple regions and hold learning collaboratives for all the regions that come together on a monthly basis. And then year 3, King and North Sound will join the implementation. And we're happy to say that current conversations have been underway with King County, and we're looking forward to next year as well. And that concludes my presentation. Jennifer.
Thanks, Edward. Before we move on to the Q&A section of this presentation, I want to take a minute, and these slides will be sent out and are available afterwards, highlighting the programs that this team supports and does work with. There's a lot of good information here. It is all linked to the work. So if you have any questions or want to learn more, please use these as resources for you, for others. They all are linked to a contact person if you have more questions. So please use them. They truly are here for you. And then also, we included a slide in today's presentation. We live in the land of acronyms. We're trying to be better about making sure we spell them all out. But this is just a quick tip of some of the acronyms that we did go over today and what they mean. So just a quick reference guide for you guys. With that, I'm going to stop sharing my screen and open the floor for questions.
Jennifer, we had a few that came through chat. I don't know if you had a chance to see them.
I have not. Oh, thank you. Becky Jensen, thank you for sharing that you are colorblind and can't read these slides. I will make sure that you get a copy that that you're able to read without the colors that will be for you specifically. So thank you for letting me know that. And I will definitely make sure I get this information to you. Diana, I interrupted you.
You're all right. I'll start. I'll read, Sherry. This one's from you, from Karen Rawl. And I'll pause first. Karen, do you want to speak to it? Or I'm happy to read it if you don't want to. Yeah, take it away.
Yeah. So this is Karen Rawl. I work for the Department of Children, Youth, and Families in King County, and I'm our Cross Systems and Mental Health Program Manager. I guess I'm just kind of, how you describe things operating is not our current experience on the ground. We'll say that. I will also say that, we're dealing with the situation in Clark County right now where, and again, serving children and adults for that matter, at the least intensive, least restrictive option is always what we want to do. And if we can get more help earlier on with outpatient services, then we avoid crisis. And if we can avoid crisis, we can avoid hospitalization. That being said, there are times where hospitalization is really the need. And what I was informed in Clark County is they no longer can get a DCR response to a youth. They call the crisis line. They're told to call the youth crisis team. The youth crisis team can't hospitalize. And so kids are not getting hospitalized at all. And I'm really concerned that if that as we look to expand these models further, we've got to figure out a solution to that. I also was hearing something about a desired 20-minute response time for youth crisis teams. Unless you plan to move to a fire station model where you have a mental health station every 10 miles in a community with people stationed 24/7 with cars that can run red lights, you are not going to get that kind of response time. So I'm curious about how this is going to actually work in reality.
Thank you, Karen, for your questions. Those are all wonderful questions, and I appreciate you asking them. So yeah, you're right. These bills, there is 1134 does mention response times for the teams, but those aren't required to become endorsed. So the teams can become voluntarily endorsed and they don't have to meet the response times in the bill. In some regions where there are youth teams that are established, they will go ahead and send when they call for a DCR, they'll go ahead and send the youth teams out first, and those youth teams can assess and see if they can keep that kid safe at home. And if they feel like there needs to be a higher level of care, they will circle back to the DCRs and loop them in. And you're right, it's a yes and situation. Yes, we need facility-based care. Yes, we need 23-hour crisis receiving centers for youth, and the MRSS teams all working together to ensure that everyone gets their needs met.
Thanks, Karen and Sherry. Next question. The 988 number has a geolocation. Does the 988 number have a geolocation component?
Currently, all calls to 988 are routed by your area code. So I have a Oregon area code. If I call 988, it's going to get answered in Oregon. They had added a geolocation subcommittee to work on that subject on the CRIS committee.
Thank you, Sherry. Betsy Jensen, are you going to go to the jails, work with pregnant women? Is this for 988 or is it for the pregnant and parenting group?
Pregnant parenting group.
Gotcha.
Well, also, I worked at a methadone clinic, and we served the jail would bring their pregnant women to us. We would do assessments and get them started on methadone. It was a great program.
Mhm.
So that's serving the infants or the babies before they're born.
Wonderful, thank you. As I'm scrolling down, excuse me, I'm embarrassed that Diana had already responded to you. So thank you for the additional candor for me. I don't see any additional questions in the chat. So I will open up to the floor. Anyone have any questions for any of us? I'll ask my question for Sherry because I'm starting to really wrap my head around the 988 and MRSS work. Do you think that if you had a youth, it's better to call the regional crisis line over 988? Or what would be your recommendation? Or how would somebody fall into, do I call 911? Do I call the regional crisis line or do I call 988?
Thanks, Jennifer. That's a great question. So, as I said, 988, these lifeline centers are confidential in nature. And so the whole goal is that people can receive support without disclosing anything. So for right now, we want to make sure that people have the regional crisis lines and to call those to access their local crisis system, including the youth teams.
Thanks, Sherry. Any other questions from the group or for the team?
Can I share something really quick? Just
Yes,
for
please.
clarification. I'm just to make sure that this was communicated, which I can't recall if I said it or not, but the residential treatment program serving pregnant and parenting individuals and their children, it does not currently have a title aside from the Grace Harbor project because it needs to be located in Grace Harbor County, but it is open to all Washington state residents.
Good to know. Betty Jensen, you have a question, and then Karen.
Well, not so much a question, but a statement. I worked at a psychiatric hospital that served youth, and their bottom line was money. It wasn't about whether the youth really had suicide ideation or not. The youth would get together and plan when they were coming back. And I thought that was really unfortunate because the system, the psychiatric hospitals can be misused. And that needs to be watched out for too.
Thank you. Thank you for sharing that, Betty. That's good knowledge for us to know and have in-house. Karen.
So with the Kids Mental Health of Washington rollout, how is this being differentiated from or working in collaboration with the existing, what in many counties are called the community resource teams that already consult on complex mental health cases and also are one part of the screening process for CLIP admissions?
I'll take that one, Karen. That's a great question. You're in King County, right? Yeah, yes. We've been working with our King County partners to talk through and think through how what is already in place can be utilized, strengthened, broadened, and what the community needs the rollout for that work, the first 6 months is community engagement. We ask the team who gets funded to go and find out across the community, across the county or region that they're covering, what's missing, what's awesome, what that group of folks who are interested in what happens for kids want to work on and prioritize. The funding, we ask it to be like first tier is to address support for kids that are not finding a way out of hospitals as first priority. And I look forward to when King County and North Sound will be our last 2 regions to come online. So they'll get funded June of 24 to start that work. And we have set it up intentionally for each region to be able to work with their communities and figure out what it should look like exactly. So it could be that it serves a broader group of young people in a different way, because it is different than the CLIP committee. This work is and can be earlier and broader, but that'll be up to the region and the steering committee that they pull together.
Okay, well, I will say King County has done what used to be called interagent staffing teams for almost 40 years, long before WISE teams, long, and we do staff cases that have nothing to do with CLIP. We staffed one yesterday. So, I mean, I guess I know we're one of the last counties to come on board. I guess part of my question was, I guess I was a little curious what maybe another county has done, but maybe that's a different topic. I will also follow along with what somebody just put on in the chat. I appreciate all of the energy and discussions that are happening, but my real concern is I'm seeing tons and tons and tons of talk, and we are not getting new providers. We are not paying our current providers enough to have workforce. We are not coming up with new beds. So you've got a lot of people holding meetings, but there's no place, I'm in hospital meetings. There's no place for this kid to discharge to. We turn cartwheels when the CLIP waiting list gets to 4 months. So without the actual resources, great, you've got more people talking to each other, but you're still not solving the problem.
Yeah, thank you for the feedback. Don't disagree, we're in a tough spot.
Any other questions for the team? Liz, I
don't have a question. I don't have a question, but I do have a comment, if it's possible. I just, this is I know Sherry she did a wonderful presentation on mobile response and stabilization services. And this does not resolve the issue that we have with beds in the state. However, it is a different type of
You're breaking up a little bit, Liz. We can't quite get to the heart of what you're trying to share. I see Latonya nodding. Thank you. I'm like the only one. I was like, you might want to put it in chat if you can still. Whoop.
We lost her.
We'll wait for her to come back. I'm guessing she'll put something in chat. If not, we'll make sure that her comments are included as they roll out, because I think she was talking about another piece of work around CLIP expansion, but I'm not sure. We're practicing the awkward pause of waiting to make sure that nobody has that last question.
You know, this is where you need that music from the game show right here.
Yes. Yes.
Yeah, that's it. Usually it's like we're do, 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 do,
Surprised Zoom hasn't worked that in already, huh? Yeah.
Well, I don't think Liz is coming back in, but we'll definitely share out with this team what she was trying to share with us in her cryptic way. Does anyone else have any other final thoughts, questions for any of us?
I just want to say thank you all for the information. It's, you know, it's a lot to absorb. I'm here in King County, so just being taken in, and I definitely am interested, and we are definitely interested in reaching out to other areas in our state just to see how things were and lessons learned and implementation. So look forward to that.
Fantastic. Fantastic. Ashley and Gina, if you want to put your email into chat, they are our technical assistance group, helping with the kids' mental health implementation, and maybe a connection there as well. I want to just say thank you to all of you for participating and recognizing and acknowledging that we're in this space and time where we don't have what we need online. A lot of it's coming, and it's there's been a lot of talking about it coming. Karen, to your point, I really appreciate you saying it. It's true. And I have hope. We have several things that that are underway that I think will relieve some of the pressure. It's not going to fix all of the challenges we have. And I encourage folks to participate or look at the Children Youth Behavioral Health Work Group has a strategic planning process that it is kicking off that's legislatively directed for the prenatal through 25 substance use mental health ADD or ASC IDD populations. And that's a place also to think about participating or sharing areas that we could learn from, that the system could learn from, but also to help us think outside the box of what exists, what could be, what should be, how should it work earlier, those sorts of things. So yes, also the CRIS committee, which I cannot, crisis response. Sherry, you want to finish the sentence and share about that one?
Yeah, the Crisis Response Improvement Strategy Committee meetings, you know, those are recorded. I'm going to pop a link in chat from our website so you can watch all the meetings to date. They just don't record the lived experience subcommittee because that's people with lived experience. But there, like I said, there's no cap to participating there. So yeah, there you go.
Thank you. I'm finding, there's the strategic plan link. I'll throw it in chat for folks. And I think, Jennifer, when these come out, do the links that came through go with the, okay, good. So you, if you're not able to grab them off of this chat, when the follow-up email comes through, they'll be there for you.
And always, if I forget anything or you have more questions, don't ever hesitate to reach out to me. Happy to help you guys navigate this very complex work that this team does, and all you as well. With that, I know we are at time. I want to say thank you for being here. I have the honor of supporting the P25 group in this work and leading this, and we can't do it without all of you guys on the ground either. So thank you for being here, for learning and holding the space and helping us do better. One other thing, we will be putting out a survey for feedback on how we can do this better in 2024. And we will pause these during ledge sessions. So you will count, once that is over, you will see these come populating back on your calendars mid to late 2024, which is crazy to even say out loud. So with that, thank you all for being here. Enjoy your month of festivities, however you facilitate and plan, and take care of yourself. So thanks, guys.
Thank you, everyone. Have a great
Thanks,
till we see you
everyone.
next.
Enjoy the rest of your day.
You too.
You too. Thank
Bye-bye.
you.
Oh my God.